Hi there, my name is Alexis Schizas. I'm a colorectal surgeon at St Thomas's, and we held the roundtable yesterday, the colorectal roundtable. I'm joined by Professor Peter Christensen from the University of Aarhus and Phil Bearn, who's a colorectal surgeon at Chertsey Hospital. So first off, we'll start, obviously, Peter, you've been here a couple of days and already seen 11 goals. So Real Madrid or Atletico Madrid, what's your preference?
Well, it's an easy draw because Real Madrid played fantastic on Tuesday night. Yesterday was awful if you were an Atletico fan because they lost 1-3. But it was a nice experience.
So I think you've spent more time at the football than most of us.
Well, I have to say it was an extension of the round table, really, wasn't it?
It was, yes.
So, and then obviously we had the round table yesterday. Phil, do you want to tell us how you feel that went and what?
I think it went, well, I hope it went very well. I certainly enjoyed presenting, and it made me read up things I probably wouldn't have read up before. I think it actually was very much involved in the subject matter, very much what we stand for at the ICS. It was very much looking at incontinence, rectal incontinence, rather than urinary, and I think it was. I think it went pretty well, didn't it?
Peter, obviously.
Yes. Well, I did not expect a crowd of 88,000 as at Stadium Bernabeu, but those plus 100 attendees was a reasonable crowd to talk to yesterday. And what I found very positive is that this is not the normal audience I show my research to. This is normally you find yourself talking into an echo chamber of colorectal surgeons and friends and fellows into your own specialty, but the true multidisciplinarity on ICS, where you can actually meet the other specialties, urology, physiotherapists, urogynecologists. This is the way you can actually bring your results and research into practice and get a broader dissemination of your knowledge.
Because low anterior section is a big problem, and a lot of it's dealt with outside of colorectal surgery by nurses, physios, not surgeons themselves. And obviously you've done a lot of work there. What would be your takeaway points for low anterior section syndrome, just briefly, if there was to tell anyone or somebody, if they see a patient with it? Is there anything you would advise just for anyone who's listening to this?
Yes, the thing that you should be aware that any cancer therapy actually comes with side effects, and if you the time has shifted towards more looking into quality of life and dealing with the side effects as cancer therapy improves. And I think you have a responsibility as clinicians to actually put this on the table with your patients. The thing in the past, you didn't ask because you didn't know what to do about the sequelae, but now we know a lot about, especially the Lars syndrome. So it is a fault if you don't ask, because then you keep therapy away from your patient, and there's low-hanging fruits out there. So ask your patients. It could be with a screening tool like as in our clinic with the Lars score, and then you put the thing on the table to discuss, and then you can take it from there, depending on what skills you have in your clinic to provide service for the patients.
So what I found really interesting was that the Lars score can be applied to other conditions, and certainly the anal conditions that I was talking about. There is effect on people's lives. It's a very full scoring system you have.
Yeah, there's some drawbacks on the score, because this is developed for rectal cancer patients actually, but since this is a short form questionnaire, it can be filled out by the patients within 15 seconds and interpreted by the clinician also in 15 seconds. Lars score should be used only in rectal cancer, but you should use short form questionnaires also to put late sequelae on the discussion as a discussion point with your patient.
And obviously, Phil, with the benign proctology, the consequences and the continence issues you can have afterwards, obviously there was disagreement and between what we like and what we don't like, because it's such a minefield with not that much evidence. I mean, anything for the benign pathology, obviously, what do you think we need to do more?
Well, I think first, I think we only had one major disagreement, wasn't it? And
One,
two. And anyone who people are welcome to look at the playback of the of the meeting then to see that. Yeah, I think benign. I think it's probably not very well taught by us to juniors. We certainly don't learn it as medical students, and it is very one of those apprenticeship things that I think I mean, how much were you taught proctology?
Not much, but I have good mentors that teaching me along the way. But one of the things when we are transforming our healthcare system now, we are not allowed to see our operative patients in clinic anymore because we want to keep them away from hospitals. There we should set up some other systems to actually have this quality control and allow patients to come back to us with their problems in some way. And I think we lose a lot of knowledge. We lose quality control if we don't, if we are not aware of the side effects and the consequences. Also, not only for rectal cancer surgery, but also for benign proctology.
I think that's right. I think a lot of the data that we base our practice on is probably a bit of hearsay, dare I say it. But a lot of the studies have been retrospective, single series. But I mean, your unit has produced some very long-term data, haven't you, over the time? But your unit is a bit of a rarity in that way. But I have to say that I think in the benign disease that we treat is actually such a common part of our practice that we really have to try and get it right. And certainly in sphincter, we talked about sphincter repairs and the evidence of how good they were in the long term when we all felt that there was probably room for improvement, room for work, and maybe a combination of SNS and sphincter repairs was something that came up, wasn't it?
And dealing with OASIS sphincter problems after the childbirth, this is a true interdisciplinary thing because the harm is done by the child and during the labor, and this is a gynecology or an obstetric issue. But then, when it becomes very severe, corrective surgeons will be involved, and there need to be a way to collaborate on these patients on basic level, but also on the very advanced level. And I think ICS is some of the meeting points for such a interdisciplinary or multidisciplinary collaboration. Yeah,
without a doubt. Certainly in proctology and anal fissure, for instance, that's in many cases due to evacuatory issues. So and if you're talking to patients who've got anal problems, then they may well have urological issues as well, and gynecological. So I think coming to a conference like this, which is very multidisciplinary, and of course, you know, much of what we do, what is our default position? We get specialist pelvic floor physiotherapists in, and it's great to hear some of the talks that I've heard from them.
Because the mainstay of both the treatments is initially sort of non-surgical management.
Absolutely.
You mentioned irrigation, pelvic floor exercises. Surgical options are limited, or what we use, or we make sure we exhaust all the medical management first. So it's always good to be in an environment like this with nurses, physios, other specialties, as well as surgeons. Is it urology, urogynae, colorectal, which is all good. And then any other highlights from the conference so far?
Yes, I would mention a pop-up meeting yesterday where I was not invited, but I party crashed this meeting, and it was a great experience to see that there is international collaboration going on between specialties in rectal and vaginal prolapse surgery, because this is another example of that you need to be aware of what's going on behind the fence, dealing with surgical issues in the pelvic floor. We tend to work in silos, but this is wrong. We need to work as a collaborative between urogynecologists, colorectal surgeons, and urologists.
There was a common theme, wasn't there, in that meeting, and that is patient-reported outcomes, where we were concentrating on maybe we were approaching a particular problem from an operative point of view, rather than we should start off from the patient's angle.
Yes, and
Which
another
is back
issue.
to your last as well, isn't
yes,
it?
it is, and
Neatly
it is also since it is obvious that there's a lack of evidence to support the clinical practice, and although we are a high volume unit where I come from, we have not that many patients, so we cannot produce out the science alone. We need to collaborate on data collection, agree on standard sets of reporting outcomes and measurements. And this was the discussion in the meeting yesterday, that can we set a basic series of prompts on imaging, on other things, standardize the procedure, and then we can start talking about quality and developing surgical methods. So but you need to come to an international meeting to get friends, and
Exactly.
here we are.
And that was an introduction.